So, good morning, everyone. Myself, Dr. Pankaj, and welcome you all in Pedia Academy by Dr. Pankaj. We are continuing our series of INISS Neonatology Fast Track Revision series. In this series, we have discussed neurology and respiratory disorders in neonates. Okay, today we will discuss the important topic GI and hepatobiliary system in neonatology. This system is itself very important. So again, this is actually very high yield series. I am just discussing crux of this topic, which are most topics which are most important for upcoming examination and easily can be missed. Okay, so again, I want your 100% attention in this series. We'll discuss many points from standard textbooks. Okay, so without further delay, let's start our discussion. Before that, do share, like, and subscribe. So, this is actually important topic as neonatology is concerned, because many things in neonatology resolves around this topic, NEC, jaundice. Okay, so jaundice in newborn, this is very much important. Why physiological jaundice appears in newborn, it's itself stand-alone question. It is due to production of bilirubin, which is increased. Why it is increased? Due to decreased RBC life, increased hematopoiesis, and UGT1A activity is decreased. These due to increased bilirubin production, leads to increased bilirubin production. It can be asked as stand-alone MCQ. Increased reabsorption from enterohepatic circulation, deficient intestinal flora, and increased intestine beta glucuronidase activity. So you have to remember all the causes. They can ask all of the none question or all above which is not there type of question. Okay, so in term, generally jaundice is the most common cause of morbidity in first week of life. That is important. It occurs in about 60% of term and 80% of preterm newborn. Okay, globally it ranks to seventh among all causes of morbidity in neonatal period. Again important. This is most common cause of readmission after discharge from birth hospitalization. Important question. In neonatal jaundice, it appears at 5 to 7 milligram per deciliter. If it rises beyond 5 to 7 milligram per deciliter, it is generally apparent. Okay, the pattern of physiological jaundice in term neonates. Jaundice bilirubin peaks at day 3 of life. Generally, it reaches to 12 to 15 milligram per deciliter. In preterm, it peaks around at 3 to 7 days, or it is generally more than 15. Okay, so this is again very much important. Jaundice on day 1, this has been asked previously. What are the possibilities? So jaundice on day 1, hemolysis, torch infection, sepsis, hepatic failure syndrome, and internal hemorrhage. So these are the causes of jaundice on day 1. So we have seen term and preterm unit, physiological jaundice criteria, and why physiological jaundice occurs. Okay, now we'll talk about pathological jaundice. So, to say pathological jaundice, it should be visible in first 24 hours. Okay, very much important. Any jaundice beyond 2 week in term and 3 week in preterm neonate will be called as pathological jaundice. Very much important. If day 1 jaundice is bilirubin is rising more than 0.3 milligram per deciliter per hour, and after day 2 if it is rising more than zero point 0.2 milligram per deciliter per hour, it will be considered as pathological jaundice. Again, this is numerical based question can be asked about these values. Okay, any jaundice more than 2 week in term neonate and more than 3 week in preterm neonate will be called as pathological jaundice. First 2 hours jaundice first, and yellow palm and sole at any time. Okay, so basically you have to remember the pathological jaundice criteria. You have to remember all these criteria. Any question can be asked by numerical value or just statement based. Okay. Again, important, American Academy of Pediatrics says TCB means transcutaneous bilirubin or TSB should be measured at 24 to 48 hours of life. Then decide on discharge whether we should repeat it again or should send the baby at home. Okay, this is mandatory criteria from up. Okay. So, are there any risk factor for developing significant hyperbilirubinemia? These can be asked. Yes, everybody knows low gestational age, jaundice less than 24 hours. Just see the risk of neonatal hemolysis suggested by rapid rise of TSB or TCB more than 0.3 milligram per deciliter per hour at age less than 24 hour and more than 0.2 milligram per deciliter per hour thereafter. There we discussed. Okay, so if this occur, this is a risk factor of significant jaundice or pathological jaundice, any family history, and Down syndrome. This is a repeat INISS question. Down syndrome has increased propensity of neonatal jaundice, macrosomic infant of diabetic mother, and exclusive breastfeeding with suboptimal intake along with jaundice less than 24 hours. So this is important. You have to remember these all criterias. These are a favorite topic of AIIMS examiners. Okay, so we'll see diagnostic feature of various type of neonatal jaundice. This is straight table from Nelson textbook of pediatrics. They say full term infant. Okay, jaundice appear at 2 to 3 days, disappear at 4 to 5 days. Peak bilirubin concentration is 10 to 12 milligram per deciliter and peak concentration come at 2 to 3 days and bilirubin accumulation milligram per deciliter per day is less than 5. In premature neonates, jaundice appears at 3 to 4 days, disappears at 7 to 9 days. Peak bilirubin concentration is around 15 milligram per deciliter. As it rises at 6 to 8 days to peak bilirubin concentration and bilirubin rate of accumulation milligram per deciliter per day is less than 5. These values can be asked in your exam, very much important. From this table, just remember hemolytic state of hematoma, mixed hemolytic and hepatotoxic factors. These in these conditions, basically if hemolysis is occurring, the rate of bilirubin accumulation can go beyond 5. Okay. So, causes of indirect hyperbilirubinemia in neonates. Basically, neonatal jaundice, what are the criterias? What are the causes? Sorry. So, hemolytic disease, immune mediated, Rh immunization, ABO incompatibility, hemolytic disease of like G6PD deficiency, pyruvate kinase deficiency, hemolytic disease like red cell membrane defect disease, hemolytic disease like hemoglobinopathies. Okay, so hemolytic disease, immune mediated red blood cell abnormalities, and hemoglobinopathies. Okay, extravascular blood, cephalohematoma, uh, enhance enterohepatic circulation. This is again important, has been asked previously many times. Intestinal obstruction, pyloric stenosis, ileus, meconium plug syndrome, cystic fibrosis, and breast milk feeding. All are the causes of enhanced enterohepatic bilirubin circulation leading to neonatal jaundice. Next, decrease hepatic bilirubin clearance. In which condition bilirubin is not cleared? Hormonal deficiency, again very much important. Hypothyroidism and hypopituitarism. Impaired bilirubin uptake. Patent ductus venosus. Just see, this is not arteriosus. Again very much important. Patent ductus venosus. And the gene SLCU1B1 gene polymorphism. This is previous year INISS question. So SLCU1B1 gene polymorphism is important. Disorders of bilirubin conjugation, UGTA1 gene variants in this condition, Crigler-Najjar type 1, type 2, Gilbert syndrome. Just remember, Crigler-Najjar type 2 is also called as Arias disease. Okay, enhance enterohepatic circulation. We have discussed in this. So enhance enterohepatic circulation leading to increase hepatic biliary load as well as decrease hepatic biliary clearance. So this is both mechanism, again previous year question. Okay, so just go through this table again, at least one question is expected out of this. Going forward, serum bilirubin measurement. So in this slide, there 3 to 4 questions are there. Serum bilirubin gold standard should be measured by HPLC. It is gold standard, but it is not feasible to measure that. So Vanderburg reaction is most commonly used in determination of serum bilirubin in neonates. What are the new methods? Spectrophotometry, conjugated optical conjunctiva optical imaging, and CO spectroscopy. So ETCO, if it is more than 2 ppm, it is suggestive of hemolysis potential MCQ. Okay, so ETCO, if it is more than 2 millimeter, it is suggestive of hemolysis. Okay, so again, I'm discussing these important topics. Just pay your 100% attention because these are I'm discussing just questions only. Okay, either they are previously asked or potential questions for upcoming exam. Okay, so what are the laboratory tests which are essential in a newborn suspected of neonatal jaundice? Blood group, okay. Mother and infant, obviously. DCT, direct comb test, it is essential, yes. Peripheral smear and G6PD level, very much important. Along with bilirubin, what are the essential tests? Blood group, direct comb test, peripheral smear, and G6PD, very much important. Optional, direct bilirubin is optional in neonates. Okay, TSH, septic screen and metabolic workup. So, what are the essential, what are the optional laboratory tests required in neonate? It can be asked as a stand-alone question. Going forward, congenital non-hemolytic unconjugated hyperbilirubinemia. We have discussed these syndrome under heading of inherited hyperbilirubinemia disorders in our gastroenterology discussion. You can check out the playlist in this channel. But for this discussion, we are discussing Crigler-Najjar type 1, type 2, and Gilbert syndrome. So severity will decrease when we will go this side. Okay. So, in this condition, serum bilirubin is more than 20, less than 20, less than 5. Okay, because severity is increased. What is major mechanism behind this? Bilirubin UGTA1 activity. In Crigler-Najjar syndrome 1, which is actually a lethal condition, it is no this enzyme activity is not detected. And in type 2, this is actually moderate, and mild Gilbert syndrome, it is decreased. Okay, hepatic bilirubin uptake is reduced in Gilbert syndrome PYQ, in which condition hepatic bilirubin uptake is decreased. Mild Gilbert syndrome, again very much important. Conjugated bilirubin in bile, absent in one, present only monoglucuronide in Crigler-Najjar type 2, and 50% of monoglucuronide is seen in Gilbert syndrome, again very much important. Total bilirubin in bile is less than 10, 50 to 100 milligram per deciliter and normal. So maximum total bilirubin is in bile found in Crigler-Najjar type 2. These are important questions. Genetics, both Crigler-Najjar type 1, type 2 are autosomal recessive, but in Gilbert syndrome, genetic polymorphism has been seen, and this is potential exam question. Thymine adenine TA7 and TA8 repeats in UGT-A1 promoter region, G211A and UGT-A1 coding sequence mutation, and linkage disequilibrium between TA7 and TA7. You are feeling it is a bit of overwhelming, but trust me, this is INISS level exam, so they will ask what is conjugated bilirubin in bile, what is composition, total bilirubin in bile, bilirubin UGT-A1 activity, and genetic polymorphism in mild Gilbert syndrome. Okay, so don't worry, just pause this video here and revise this table once here only. Okay, so just see this table, and this is actually a source of many question in upcoming exam. Going forward, phototherapy. CFL is most common used device because it is easy. Again, question. LED. Generally, we use this is most we used nowadays. What are the LED advantages? It is longer life, narrow emission spectrum, less infrared radiations, so less water loss, less heat production. Okay, so these are the some advantages can be asked as statement based question. Nowadays, fiber optic phototherapy devices are used. Generally, Billy blanket is the example. Generally, they are used to provide under surface phototherapy to increase the efficacy of phototherapy. Okay, so what is the radiance in phototherapy? Statement or plain question. At least 30 microwatt per centimeter square per nanometer irradiance. Okay, what should be the wavelength of phototherapy? Between 460 to 490 nanometer. Okay, so these two values can be asked. If effective phototherapy, we will call if decrease in TSB, total serum bilirubin, by at least 2 milligram per deciliter within 4 to 6 hours of initiation. So this is criteria of effective phototherapy. Again, very much important. What are the contraindication of phototherapy? Absolute contraindication is congenital porphyria. Again, very much important. Okay, conjugated hyperbilirubinemia, it is not a contraindication. If patient is sick or LBW, it is not a contraindication. Obviously, it will cause bronch baby syndrome, but if patient is sick or LBW, we can continue phototherapy. It is not a contraindication. Okay, so, what are the indication of phototherapy? Indication of phototherapy. We know TSB level at the above phototherapy threshold. Yes, obviously we will give. Neonatal feature of bind bilirubin induced neurological disorder. We will discuss this disorder in detail after some time. Home based phototherapy. This is actually new addition in new protocols. We'll discuss that also. But what are the criteria of home-based LED phototherapy? When TSB is not more than 1 milligram per deciliter above phototherapy cutoff and the neonate is otherwise well and no risk factor, with daily monitoring of TSB can be ensured. Okay, so we can send them those neonates to home for phototherapy. Okay, again very much important. After phototherapy, you should check TSB every 4 to 6 hours. Okay, because it might rise, hemolysis can occur, but discontinue once total serum bilirubin is less than 2 milligram per deciliter below threshold. Okay, if it is less than 2 milligram per deciliter below threshold, you can stop. How you will check rebound jaundice after stopping phototherapy? Preferentially, it should be seen in 24-hour by transcutaneous bilirubin. Okay, generally we see in 12 hours. Okay, so transcutaneous bilirubin you can use after 24 hours. This is again important. Okay, but if neonate is less than 38 week plus risk factors are there, you have to check the rebound increase in bilirubin in 6 hours. Obviously not from TCB, you have checked from serum values of bilirubin. Okay. Uh, Exchange transfusion. What are the indication of exchange transfusion? Acute bilirubin encephalopathy. Yes, irrespective of any TSP level, you have to do exchange. Okay, TSP level above exchange cutoff. That is obvious. Again, very much important. In RH isoimmunized neonate, if code bilirubin is 5 milligram per deciliter, or code HB is 10 gram per deciliter, this is the criteria of exchange transfusion. Okay. However, this statement is very important. If baby shows sign of hydrops or cardiac decompression in the presence of low PCV less than 35, partial exchange transfusion with 50 ml per kg of packed cell should be done to restore oxygen carrying capacity of blood. Mark this statement. This statement can be asked as statement based question. Okay. DVT may be considered when bilirubin to albumin ratio exceeds the age-specific cutoff. We'll discuss those age-specific cutoff also. As of now, these are the indication of exchange transfusion. Okay, so type or volume of blood for exchange transfusion is very important for exam purpose. Just pay your attention here. In RH immunization, what type of blood we should use for exchange transfusion? It should be RH negative and blood group O. Okay, so this is O negative or that of the baby. Okay, either it is should be O negative or baby blood group for RH immunization. Obviously, you have to cross match with baby and mother blood. This is important. Suspended in AB plasma. If the condition is ABO incompatibility, so RH compatible and blood group O, note that of baby, very much important. Okay, so baby blood group should not be there in ABO incompatibility exchange transfusion, very much important. The pathophysiology behind this we'll discuss in separate video, but as of now just remember baby blood group is not required, not recommended in ABO incompatibility. Okay, other conditions like G6PD deficiency, non-hemolytic or other isoimmune hemolytic jaundice, baby blood group and RH typing is required. Okay, so volume of the blood we know this is double volume. To prepare DVT, mix 2/3 of PRC plus 1/3 of plasma. So this is important. 2/3 of PRC and 1/3 of plasma should ideally be mixed. What are the acute manifestation of bilirubin encephalopathy? So this is important. It can be divided into early, intermediate and advanced. So lethargy, hypotonia and just keyword is there high pitched cry. If high pitched cry is mentioned anywhere, it is early manifestation of bilirubin encephalopathy. In intermediate version, hypertonia, fever, seizures and irritability develop. This phase leads to chronic bilirubin encephalopathy. An advanced stage, shrill cry. This is again keyword, shrill cry, pronounced hypertonia, apnea, seizure, coma. So this stage is very lethal. Generally, infant die in this phase. Okay. So this another table which divides early, moderate, advanced. So early we have seen this high pitched cry pattern. Okay, moderate neck and back arching and shrill, difficult to control. So in advanced, weak or absent cry. Okay, shrill cry is seen in moderate to advanced. You can remember from AIIMS protocol and Cloharty actually differ from this. Persistent retrocolis and seizures are seen in advance. Okay, so this is common sense. If high pitch cry seen in early, shrill cry is moderate to advanced, and seizures and actually seizure and encephalopathy leading to intermediate to advanced bilirubin neuropathy. Okay, what are the neurotoxicity risk factors in neonate came in your NICU, and how you can predict this neonate can go to neurotoxicity in neonatal jaundice if gestation is less than 38 with risk factor increased risk of prematurity. Albumin is less than 3 gram per deciliter, very much important. You did albumin levels and they are less than 3 gram per deciliter. It is a risk factor of neurotoxicity. Okay, isoimmunohemolytic disease like positive DAT, G6PD deficiency, and other hemolytic condition, sepsis, and significant clinical instability in previous 24 hours. These are the neurotoxicity risk factors. Okay, so we have discussed bilirubin to albumin threshold at which consider exchange transfusion, very much important. Just remember three things: as infant more than 38 week, infant 35 to 37 week, with week and well and more than 38 week with at least one hyperbilirubinemia neurotoxicity risk factors, an infant 35 to 37 week with at least one risk factor. Okay, just see a risk category and just remember TSB, total serum bilirubin to albumin ratio cutoff. This is very much important. Just remember the this 8, 7.2 and 6.8. So just remember this ratio is 8, 7.2 and 6.8. Very much important. So this is potential MCQ in your upcoming exam. Okay, so this is eligibility of discharge infant for home-based phototherapy. So we have discussed this earlier also. The important point to consider in this table is TSP level no more than 1 milligram per deciliter above phototherapy threshold. Other are baby should be well, no non-clinical risk factor should be there, no bilirubin neurotoxicity, no previous use of phototherapy, okay, or capacity of daily TSB measurement should be there. So these are the home-based phototherapy criteria. This is also potential MCQ. Okay, so now clinical feature of connectivus. Okay, so this is actually this is important, that's why I'm discussing. This is from Nelson. Phase 1 that lasts from 1 to 2 days, which leads to poor suck, stupor, hypotonia, seizures. Phase 2 middle of first week, hypertonia of extensor muscle, opisthotonus, fever. Phase 3 after first week, hypertonia. So in this condition, acute form, phase 1, phase 2, phase 3. So phase 1 has seizures, poor suck. Phase 2 hypertonia of extensor muscles and fever. Chronic form. So in chronic form, first year, what happened in first year? Hypotonia. Just remember, first year it is hypotonia, active deep tendon reflexes, obligatory tonic neck reflexes and delayed motor skill. They can ask in first year what manifestations are seen in connectivus. So again to revise, hypotonia, active deep tendon reflex, obligatory tonic neck reflex and delayed motor skill. After first year, movement disorders like chorioathetosis, balismus, tremors, upward gaze, and SN hearing loss. So this is triad. Okay, SN hearing loss, upward gaze, and movement disorders. So you have to remember all clinical features of connectivus. Very much important. Okay, so this is MRI image which is suggestive of high intensity in globus pallidus in case of connectivus. Okay, if we do the post-mortem section or brain section of this, deep yellow staining is seen in globus pallidus. These both images can be asked. Okay, so there is important change in 2022 revision of American Academy of Pediatric guidelines of neonatal jaundice. So this is very much important and it is potential MCQ. Statement based question can be asked. Just revise with me. Maternal screening for anti-erythrocyte antibodies in Rh negative mother, if positive, to test infant for blood group and DAT. Okay, so this is actually anti-erythrocyte antibody testing is required in Rh negative mother. This is one caution. Okay, another one is universal TSP or TCB screening is recommended between 24 to 48 hours prior to discharge if earlier. Listen, this statement based question can be asked, so this you have to remember. Okay, risk factor addition, Down syndrome has been added in this. So Down syndrome is a risk factor of neonatal jaundice. Okay, omission, maternal age, male gender, East Asian race are excluded. Okay, so maternal age is not a criteria for bilirubin neonatal jaundice. Male gender, no, male and female are equal. Neurotoxicity risk factors, gestational age less than 38, albumin less than 3, sepsis, hemolytic condition, significant clinical instability in previous 24 hours. We have discussed this also, but this is again new change. Okay. Uh, Breastfeeding jaundice has been renamed as suboptimal intake hyperbilirubinemia. Again, very much important. Home-based phototherapy criteria we have discussed, more than 38 week, and TSB concentration no more than 1 milligram per deciliter above phototherapy range. Phototherapy can be discontinued when TSB fall less than 2 milligram per deciliter. So this is again very much important. Okay, if TSB is less than 2 milligram per deciliter of range, you can discontinue phototherapy. Okay, timing of measurement. On the day of phototherapy stop, at least 12 hours, preferably 24 hours. We have discussed this. Okay, TCB can be used if at least 24 hours after stopping of PT. Again, stand-alone caution. TCB can be measured after 24 hours. Okay, 2 milligram per deciliter below exchange threshold defined as escalation of care threshold. So they can ask escalation of care threshold is 2 milligram per deciliter below exchange threshold. Okay, IVIG in isoimmune hemolytic disease can be considered. Okay, exchange transfusion is recommended for ABO TSB at exchange cutoff. Hematocrit of blood in exchange transfusion, which should be 40% hematocrit for exchange transfusion for benefit of this increased bilirubin clearance. Okay, so till now we have discussed extensively with actually neonatal jaundice. This is important topic in this hepatobiliary GI and hepatobiliary system of neonate. So just revise this neonatal jaundice once again. I have actually covered all the topics in neonatal jaundice which can be asked in exam. Going forward to NEC. Okay, so just remember, first staging of NEC, modified Bell staging, stage 1, stage 2A, stage 2B, 3A and 3B. Just remember the actually key points or just indicators which can be asked, key words, sorry. So just remember, if in question it is mentioned occult blood in stool, okay, this should be stage 1A. Just remember, I am giving the trick to you because this is complicated question. This will be complicated question. Gross blood in stool, if it is given, you have to search for keywords. It is stage 1B. Okay. If ileus is mentioned, pneumostasis intestinal is maintained or X-ray is given, it is stage 2A, 2A. If portal vein gas is given, this is stage 2B. Okay. If definitive ascites is given or X-ray image is given, it is stage 3A. If it is pneumoperitoneum is given, it should be stage 3B. Okay, so you have to remember staging. They are fond of asking staging of NEC. So just remember keywords for staging. Okay, so stage 1 NEC generally seen in on nasal mask ventilation. Okay, just see, okay, sorry. So just imposter of necrotizing enterocolitis will focus on ischemic bowel due to cardiac anomalies. Okay, if cardiac anomaly is there, so bowel can be ischemic. Okay, it can be confused with NEC. Okay, so you have to differentiate it. Protein intolerance syndrome. So food protein intolerance syndrome, FPIES, you have to see if it is not food intolerance. So these two entity you can remember as the imposter of necrotizing enterocolitis. Okay, so these X-ray can be asked. So this is actually a dilated air filled loop. You can see air filled loop. Okay, so this is primary stage of NEC. You are able to see intraluminar air in this X-ray. Okay, portal vein in this X-ray, we have discussed the classification according to Bell staging. Go there and classify them. Okay, as of now, portal, this is portal gas. Okay, air under diaphragm, it is showing perforation. Okay, so these X-rays can be asked. Again, USG of NEC suggestive bowel perforation gas is there. Okay, again to see hepatic portal venous gas. So you are able to identify here, this is hepatic portal venous gas, and This is bubbly appearance of stomach in pneumostasis intestinalis. These two findings are pathognomic of NEC. So these can be asked, what are the pathognomic finding of NEC in X-ray? So these are two findings in this X-ray can be asked. Staging, Bell staging can be asked according to this. In this X-ray, pneumoperitoneum can be seen. Okay, so this is pneumoperitoneum. Okay, so this X-ray suggests of intestinal perforation, cross-table abdominal radiograph, air below anterior abdominal wall is seen. So these X-ray are important. Okay, pathogenesis. One question has been asked on pathogenesis. So what are the receptors? Toll-like receptor 4, okay, interleukin 18 or FUT2, okay, and lower ratio of fork head box protein FOXP3 plus T, platelet activating factor PAF, okay. So actually you have to remember these conditions because this once platelet activation factor was asked, so this was PYQ, okay. Okay, going forward to initial feeding method. Now we are in nutrition part of newborn, especially very low birth weight or low birth weight neonate. Okay, so just see, less than 28 week, no proper sucking effort is there, no propulsive motility in gut. 28 to 31 week sucking burst develop. Okay, so they can ask at what gestation age sucking burst develop. It is 28 to 31 week. No coordination between suck, swallow, and breathing. 32 to 34 week, slightly mature sucking pattern. Coordination between breathing and swallowing begins. Okay, so more than 34 week, this is mature pattern. So in this, they can ask suckling bursts develop at 28 to 31 week. Okay, and coordination between breathing and swallowing begins at 30 to 34 week and it get mature at more than 34 weeks. So you have to remember this. What are the feeding methods? If the neonate is more than 34 weeks, just start breastfeeding. Okay, so observe it with good attachment and long enough feeding is there, more 10 to 15 minutes. Okay, if the neonate is 32 to 34 weeks, start feeding by spoon, very much important. Okay, and if neonate is 28 to 31 weeks, start feeding with OG or NG tube. The pre-feed aspirate exceeds more than 25% of volume. It is feed intolerance. We will discuss feed intolerance in detail also. And less than 27 weeks, start IV fluid. Okay, so this is feeding ladder of neonatal nutrition, especially according to gestational age. You have to remember all the criteria and cutoff statement or clinical scenario based question can be asked. Going forward, oral feeding preterm LBW. Okay, preterm LBW was there and you started that neonate on IV fluids. Okay, if the neonate is hemodynamically stable, you have to start trophic feeds. We'll discuss how much trophic feed will be given in next slide. Okay, so monitor with feed intolerance. If feed intolerance is not there, you have to gradually increase the feed volume, taper and stop IV fluid. Then you have to put the neonate on OG infant on OG tube and feeding. At 30 to 32 week of gestation, try spoon feed. Generally increase the amount and reduce OG feeding. And when the neonate is on spoon on palliative feeding, put them on mother breast. Okay, and taper the or stop spoon feeding. So this is oral feeding progression. This slide was for starting, how we will start, and this is how we will progress. So you have to remember both. These are guidelines of nutritional supplement for infants with birth weight. Uh, actually, 1.5 kg to 2.5 kg. Vitamin D, you have to give vitamin D 400 international units per day till 2 years of age, very much important, and you have to start at 2 week of age. Along with iron, it should be given as 2 milligram per kg per day, should be started 4 week of age, not 2 week. Okay, after 1 month till 2 years of age. So this is again very much important. LBW supplementation. This is LBW supplementation guidelines. Okay, vitamin D and iron should be started. Just remember at 2 week, 4 week age, and till 2 years respectively. Okay, going forward to nutrition supplementation preterm PLBW. Okay, till 40 week of gestation. Okay, so options are we have to fortify it with HMF, and if financial constraint are there, so we can mix it with preterm formula also. Just remember, if we are giving HMF to child, no calcium, no phosphorus, no vitamin D, no folic acid, no iron is needed in HMF. Again, practical and very important question. But zinc and vitamin B6A, zinc, vitamin A and B6 are generally required. So we'll start multivitamin drop in HMF. Okay, very much important conceptual question. In preterm formula, everything is required: calcium, phosphorus, vitamin D, folic acid, and iron also. Okay, so this is again very important. If the VLBW infant crosses 40 week of gestation, okay, so what you will give? Okay, you will give vitamin D and iron as we discussed till 2 years of age. Okay, so this is approach of feed intolerance in LBW. In previous flow charts, we have discussed feed, how we should start feed to LBW and continue feeding. In this, if feed intolerance develops, okay, so if abdominal girth is more than 2 centimeter, or patient is vomiting altered milk, so you have to aspirate the stomach content. So this is again question: what are the criteria of aspiration of stomach content in neonate? If increase in ag is more than 2 centimeter, altered milk like bile, blood is seen in, you have to aspirate. Okay, if you have aspirated that milk content of gastric content, see if it is bile or blood stained. Okay, so if it is bile or blood stained, just wait for 24 to 48 hours and evaluate the patient with X-ray or USG. Okay, if the gastric content clear, not bile or blood stain. If aspirate volume is less than 2 to 3 ml or less than 25% of feed volume, it can be transient. Just look for local cause and continue feeding, monitor. Okay. If aspirate volume is 25 to 50% of feed volume, you have to reduce feed, and if aspirate volume is more than 50%, withhold two feeds. Okay, so any clinical scenario can be made. If aspiration volume is more than 50%, what we will do: stop feeding, reduce feeding, or skip two feeds. Okay, so these are important. You have to remember these, or imagine a scenario in your mind according to this. Make a mind map. Okay, feed intolerance if recur, you have to assess the child unit clinically. If systemic signs are there, baby is sick, you have to withhold feed for 24 to 48 hours and evaluate systemic cause. And if no systemic signs are there, so you have to see the OG position and withhold feed for 12 to 24 hours. This flow chart is simple looking, but trust me, when a long clinical scenario, long stem based question is made, people generally tend to confuse it. Okay, so just be aware of these criterias: what are the aspiration volume and bile stain and other thing. Okay, so you have to remember, because one question can be made: if aspiration is gastric contents are bile stain but they are less than 25% feed volume, what you'll do? You'll just monitor. No, you have to stop feed for 24 to 48 hours, like that. Okay, going forward to desired gain in anthropometric parameters. So length should be 0.7 to 1 centimeter per week, should increase. HC should increase 0.7 to 1 centimeter per week. Okay, weight gain velocity is should be 15 to 20 gram per kg till 36 pma, and 20 to 35 gram per day from 36 week of pma to 2 month of corrected age. You have to remember all these. Okay, Growth chart used in NICU. These are two type of chart, obviously intrauterine and postnatal. So example of intrauterine growth charts are Levencho, AIIMS chart, intragrowth 21 chart, and postnatal chart are intergrowth 21, PPFS and WHO MGRS. Okay. So actually 30-week gestation, 1.2 kg week weight or postnatal growth monitoring, you have to remember intergrowth, Fenton charts. After 40 week of gestation, 2.9 kg weight or postnatal growth monitoring, we generally use WHO MGRS charts for these units. Okay, again, this flow chart is also important. This shows algorithm of feeding infant with uh, AREDF. Basically, this is absent flow in umbilical actually vasculature. Okay, so this is important if USG finding suggestive of that. Okay, look, if gestation is less than 35 week, okay, and birth weight is less than 1.2 kg, what you'll do? In this condition, men start at men after 24 hours at 10 ml per kg per day. Very much important. If gestation is less than 28 week, continue man minimal enteral nutrition for 48 hours, then increase feed at 10 to 20 ml per kg per day. If gestation is more than 28 weeks, you can start increasing feed at 10 to 20 ml per kg per day. Okay, on the right hand of the stem, if birth weight is more than 1.2 kg, start man at day 1. Very much important. Okay, so the consideration is if birth weight is 1.2 kg, start man after 24 hours. If birth weight is more than 1.2 kg, start man as day 1 itself. Okay, and the rate of increase is also more, 20 to 30 ml per kg per day in birth weight more than 1.25 kg. Okay, this is important. Okay, so again, add fortification once baby tolerates 100 ml per kg or per day feed, or increase feed to 150 to 180 ml ml per kg per day. Okay, check for gastric residue of Ag more than 2 centimeter, we have discussed. Okay, so this is also simple looking table, but many questions are there. Okay, if birth weight is more than 1.2, if birth weight is 1100 gram, okay, and if baby is 27 week, we have to continue man for 48 hour before going forward to increasing of feed. So you have to remember these guidelines. These can be asked as a scenario based, long stem based question. Okay, so now we are going towards actually hepatobiliary system of neonates. What are the neonatal liver failure cause? We'll discuss neonatal liver failure cause in detail also. Generally, we see gestation alloimmune liver disease, HLH, mitochondrial viral ischemic. How you will differentiate? Just see one thing: ferritin levels. Ferritin levels are high in two conditions: HLH and viral. So, how you will differentiate HLH and viral on the base of ferritin level? No, you can't. But just see, triglyceride levels are increased in HLH. Okay, if you are suspecting mitochondrial disorders, you will see lactic acidosis and alpha fetoprotein levels are increased. Okay, that's how you can differentiate these things. HLS has different a list of criteria I will not discuss here, but as of now you can see. Okay, so I'm not going through this complete table. Just pause this video and revise this again. But on the actually discussion is on differentiating point of ferritin, triglyceride, and lactic acidosis we have discussed. Okay, so cholestasis causes we all are familiar. Just I'm highlighting important one. This actually which are important to exam upcoming exam. Okay, extrahepatic biliary atresia. New infant is otherwise well, very much important. Liver shows portal expansion. Small size gallbladder is seen less than 9 millimeter, 19 millimeter. So these are the keywords which are important for diagnosis. Choledochal cyst. USG or MRI suggestive of cyst. Insipid bile duct syndrome. Okay, so in this condition, the history of phototherapy, exchange transfusion, or after ceftriaxone IV. So the treatment is ursodeoxycholic acid and may require intraoperative flushing of bile ducts. Very much important. Okay, PFIC we have discussed. PFIC3. So elevated GGT is seen in PFIC3, all we know. In PFIC, this is actually important criteria. Alpha 1 antitrypsin deficiency. Just remember one thing, alpha 1 antitrypsin levels are often falsely low in neonates. Very important. Galactosemia, E. coli sepsis. This year, this question has been asked in tests. Neonatal liver failure, one of the cause of neonatal liver failure. Okay, you have to do urine for non-glucose reducing substances. Baby should be on galactose containing diet at the time of testing. Going forward, tyrosinemia type 1, it is also cause of neonatal liver failure. You have to do FPH examination. And what is the therapy? Important question. Nitisinone with low phenylalanine or tyrosine formula you have to give. OTC deficiency, low citrulline, high glutamine in blood with hyperammonemia, and you have to decrease hyperammonemia by arginine, sodium benzoate and sodium phenyl acetate. Fatty acid oxidation defect, it leads to hypoketotic hypoglycemia. Herpes simplex 1 and 2 is neonatal liver failure in first week of life, which is important. Cytomegalovirus, PCR from urine or blood is investigation of choice, and the drug of choice is IV ganciclovir for 21 days. Alagille syndrome, as we discussed earlier also, many features are there. Just to highlight, posterior embryotoxin and the gene JAG1 and OH2. We have discussed this Alagille syndrome detail in our full based video. Just see in our channel. Okay, panhypopituitarism adrenal insufficiency. In this condition, it may mimic sepsis, hypoglycemia. Just see neonatal hematochromatosis due to GALD, very much important. In this condition, the low transferrin saturation is more than 95%. Salivary gland biopsy from lips is shows iron deposition, pearl staining, very much important. The treatment is IV, IG and double volume exchange transfusion. Mitochondrial disorders, as we discussed also, hypoglycemia, lactate to pyruvate ratio is more than 20, ketonemia is seen. Okay, so how we will approach to neonatal cholestasis? Just see, if neonate comes with neonatal cholestasis, if see the neonate is sick or well. If it is sick, just see sepsis can be there. Okay, first possibility. But are sepsis mimic of neonatal cholestasis? You have to remember, this is potential MCQ. Okay, galactosemia, tyrosinemia, hematochromatosis, okay, fatty oxidation defect, mitochondrial hepatopathy, urea cycle defect, and hypocortisolism. So these are the points which can seen as sick newborn having sepsis like features. Neonatal liver failure. So, neonatal hematochromatosis, HLH, metabolic liver disease, and urgent investigation of specific therapy is required. So, this is sick newborn algorithm for neonatal cholestasis. If you found the newborn is well, so just see if the neonate having pigmented stool. Yes, you have to do ultrasound GGT. So PFIC you should consider. If PFIC 1 and 2 the GGT levels are normal and PFIC 3 GGT levels are high, very much important. But pale stools are there, you have to, alarm should ring in your mind as a pediatrician to rule out biliary atresia. You have to do ultrasound, HIDA scan, liver biopsy, and pre-operative cholangiogram in investigation of choice of these type of disorder. Again, very much important. Okay, so daily vitamin and mineral requirement in neonatal cholestasis. This vitamin K was asked in tests previously. So the vitamin K will start with vitamin K 2.5 milligram bi-weekly to 5 milligram per day orally. But if see they ask parenterally, it is 2.5 to 5 milligram for weekly parenterally, very much important. Vitamin A they can ask 5,000 to 25,000 international unit per daily. Vitamin D 400 to 1200, vitamin E 50 to 400, calcium 20 to 100, zinc 1 milligram per kg per day. So these are important. Going forward to next, common surgical condition of their salient features. I'll not discuss this table as a whole. Just pause this video. I'll discuss pause this video and look this table if you want to see it completely. I'll discuss just important points from this table. Okay, so pyloric atresia, as all we know, single bubble appearance is seen. Duodenal atresia is double bubble appearance seen. Just remember, malrotation of mid-gut volvulus. This is actually hemodynamic instability condition, and in this condition the abdomen is tensionally distended. Okay, so if you found hemodynamic instability and you are suspecting surgical abdomen, just don't forget malrotation and mid-gut volvulus. Okay, meconium ileus, cystic fibrosis should be ruled out if you have diagnosed cystic meconium ileus. Okay, meconium peritonitis, colonic atresia. Okay, and Hirschsprung disease are the generally surgical conditions. Okay, so this was previous PYQ from INISS. In this diagram, are you able to appreciate abnormal anal opening? Yes, this is case of abnormal anal opening. Okay, in this condition, only hyperpigmentation on the supposed site of anal sites. This is anal atresia. In female, vestibular fistula is most common anorectal anomaly. Yeah, this is just posterior to introitiae. Okay, so this is vestibular fistula. You're able to see just posterior to introitiae. Okay, so vestibular fistula is most common in female. Okay, this is male neonate with a low type of anomaly. It is diagnosed by presence of meconium in subepithelial tract. Meconium pulse, it is called, reaching up to the scrotal raphe. Very much important. And this image is suggestive of common channel cloaca receiving urethra, vagina and bowel in all one. Okay. So this is flow chart suggestive of suspected in neonatal intestinal obstruction. Just pay attention on this. This is very important. Okay, I'll discuss this chart in actually by dividing in multiple subtypes. Okay, so a neonate came with feeding intolerance. Okay, abdomen distension. Okay, just first you have to see anal opening if it is present or not. If anal opening is not there, just uh, anorectal malformation is diagnosed and managed accordingly. Anorectal malformation surgically or many things are available, but you found anal opening is there. Okay, so you see you have to rule out sepsis or NAC by X-ray and blood investigation. Okay, now you'll see if vomiting is bilious or not. You see vomiting is not bilious. So you are actually left with two diagnoses: pyloric atresia and duodenal atresia. Simple thing. Pyloric atresia will show single bubble appearance on X-ray, and duodenal atresia will show double bubble of X-ray. So till now we have discussed this part of our flow chart when no anorectal malformation is seen and no bilious vomiting. But what happens if bilious vomiting is there? Okay, then the plethora of diagnosis possibility are there. Okay, just see the any double bubble, triple bubble we have discussed. Okay, dilated stomach or meconium peritonitis, meconium ileus. Okay, microcolon with cutoff with colon, microcolon with no cutoff contrasting colon. Okay, so just go through this part of chart. This is important. You have to go through because this is just simple understanding of what is happening. Due to time constraint, I am not discussing all this chart, but yes, these you have to remember. This actually initial division is important, and later you can read this by pausing this video. Okay, energy requirement of low birth weight infant. This can be asked in exam. From my side, just remember resting BMR is like 40 to 50 kilocalorie per day. Energy intake is 90 to 120 kilocalorie per day. Okay, MCT oil contains 8.3 kilocalorie per gram energy content. Okay, and protein like Abbott nutrition is extensively hydrolyzed casein formula 3.6 kilocalorie per gram. So just remember these value might be asked in exam. Okay, indication of use of infant formula, again very much important. Any infant which is allergic to cow milk protein allergy, you have to do extensive hydrolyzed formula. Bronchopulmonary dysplasia, high energy and nutrient dense. Biliary atresia, potential MCQ again. This is actually semi-elemental containing reduced LCT and supplement MCT 55%. Congestive heart failure, high energy formula. Cystic fibrosis, LCT and MCT supplementation. Galactosemia, soya based formula which should be lactose free. Okay, hepatic insufficiency like biliary atresia, it is containing LCT 45%, MCT 55%. Okay, lactose intolerance, low lactose formula. Again, renal insufficiency, Similac formula, low for phosphate content, low renal solute load. So you have to remember the indication of use of infant formulas. Okay, this is again very much important around breast milk caution. On room temperature, we can keep the fresh express mother milk to 4 hours, frozen mother milk at 4 hours, and pasteurized donor milk at 4 hours. But just remember, the room temperature should be 16 to 29. So in this summer season it is not possible. So just counsel your patients also at a room temperature, means the room should be at 16 to 29. The 4 hours is the cutoff for express breast milk or frozen milk. Okay, in the refrigerator, if the temperature is 4 degree, fresh milk at 96 hours, frozen milk at 48, and pasteurized is 48. Freezer, okay, minus 18 degree, 9 month, 6 to 8 month, and deep freezer, laboratory freezer, and 12 months they are giving. So nobody using this, but these are the actually basically 12-month cutoffs. Okay, so you have to remember room temperature and refrigerator cutoff. What are the there for breast milk? Okay, contraindication of breastfeeding is again very much important. Okay, what are the absolute contraindication? Galactosemia is absolute contraindication. Active untreated tuberculosis is contraindication. Okay, and CDC recommend HIV positive in United States. Okay, but in our country we use a fast criteria affordable, that a fast criteria is used for HIV. Okay, so I'm mentioning Nelson point of view in this table. Okay, which are not contraindication of breastfeeding. These are important. Hepatitis B, not a contraindication. Hepatitis C, CMV, febrile patient, COVID-19 positive or exposed, not a contraindication. Okay, tobacco smoking is not a contraindication, but you have mother have to reduce it. Alcohol generally is not a contraindication, but mother should avoid breastfeeding for 2 hours after the drink. Okay, so this is actually from Everest. What are the contraindication of breastfeeding? Classical galactosemia we have discussed. HIV in Western countries, in our country, AFAS is used, and in drug use, Ebola virus. Okay, so Ebola virus again very much potential MCQ. Ebola virus, we generally breastfeeding is contraindicated. Temporary restriction in untreated tuberculosis, brucellosis, any medication, herpes simplex HSV infection. Okay, and temporary restriction or may use express breast milk in case of active varicella, untreated tuberculosis. Okay, so these are important. So, estimated protein, energy, and trace element requirement is very much important. You have to remember the highlighted one. Okay, chromium. Chromium is not sorry. Chromium is not required in preterm. Why? Because chromium contamination parenteral nutrition product is there. So no additional chromium is recommended in preterm neonate. Very much important. Iron, you have to remember, 200 to 250 microgram per kg per day is required in preterm, and in term it is 50 to 100 microgram per kg per day. Zinc, the only supplementation which is required on day 1 on parenteral nutrition is zinc. The value is 400 to 500 microgram per kg per day, and term 250 microgram per kg per day. So you have to remember at least highlighted points in this discussion. Okay. Similarly, folic acid is 56 folic dose per kg per day, and 56 in term also. Vitamin K you have to remember, vitamin D you have to remember, vitamin A you have to remember. Okay, and monitoring of parental nutrition, magnesium, triglyceride, AST, and GGT. So you have to just remember these are actually numerical based question or fact based question can be asked. So this is bronchoscopy suggestive of H type of tracheoesophageal fistula. Just see, this is H type, and this image is, I think, PYQ. This is body stalk abnormalities, also called as limb body wall complex. So this image directly can be asked. Just go through it once. Okay, gastroschisis and omphalocele differentiation is favorite topic of AIIMS examiners. Okay, just see location of abdominal wall defect, right of umbilical cord in gastroschisis. Omphalocele, it is midline, include umbilical cord. Okay, covering membrane is are not present in gastroschisis and they are present in omphalocele. Umbilical cord insertion is normal and in this condition into omphalocele membrane. 100 organs, bowel generally seen, but liver is commonly seen in omphalocele. Very important. Associated anomalies like chromosomal syndrome, cardiac association are more common in omphalocele. Just remember, but bowel atresia are more common in this gastroschisis. Very much important. Major determinant of clinical outcome are condition function of bowel because bowel atresia is seen, and in this omphalocele associated anomalies are most important determinant. So mark my word, this is very much important. You have to remember all these. Okay, urethral abnormalities. Just see, this is simple looking diagram and many question can be framed from this. This is bladder. Okay, this is umbilicus. If there is no connection, it is normal. If any uric polyp is there from umbilicus side, this will be called a urethral polyp. If any sinus from umbilicus is seen, urethral sinus, because just see, this is urethral. Okay, if any out poaching from bladder side, it is bladder diverticulum. If it is in between, it is urethral cyst. And if they both are connected, this is patent urethus. Very much important. Okay, omphalomesenteric duct abnormalities is also important. Umbilicus is same from this side like this. Okay, bladder is replaced by GI tract. Okay, in GI tract umbilicus, if it is no connection, it is normal. Okay, if outpoaching of umbilicus is seen similar to urethral polyp, it is also called as polyp, but now it will called as omphalomesenteric duct polyp. Okay, and if it is sinus is there, it will be called omphalomesenteric duct sinus, similar to urethral sinus. And if it is GI tract showing diverticulum, similar to bladder diverticulum, it will be called as Meckel diverticulum. And similar to urethral cyst, omphalomesenteric duct cyst is seen. And patent omphalomesenteric duct is connection between GI and umbilicus. You have to remember all these. Okay, umbilical cord abnormality. Just I want to highlight single umbilical artery. In this condition, it is incidence is 0.5 to 1%, and in this condition, association are stillbirth, IUGR, multiple gestation, stillbirth, risk of genitourinary abnormalities and chromosomal abnormalities. Okay, so this is actually algorithm of infant with conjugated hyperbilirubinemia. You have to remember, you have to do liver ultrasound. colorectal cyst, if you found, you have to refer for surgery. Liver biopsy, intraoperative cholangiogram, again biliary atresia is investigation of choice. Okay, these are some slides of neonatal hepatitis. In this, actually, germ cells can be seen, and transformation, ballooning of hepatocyte is seen. Biliary atresia histology can be asked. Proliferation of bile duct plus bile pigment is seen in biliary atresia. This is fibrous expansion of portal tract. This is actually extra points you can remember if you want. Okay, this is table is important. What are the causes of acute liver failure in children? Neonates, very much important. The causes are galactosemia, tyrosinemia, hereditary fructose intolerance, mitochondrial disease, fatty acid oxidation defect, and GLD. So they can ask anything about the question which condition can leads to acute liver failure in neonates. Encephalopathy, encephalopathy in fatty acid oxidation, organic acidemia, urea cycle disorders, and paroxysmal disorders. Okay, so you have to remember all. So causes of neonatal acute liver failure, you have to see this. Okay, in this condition, we have discussed these condition. Okay, and immune mediated conditions, vascular, drug, neoplastic, all are important considerations. Acute liver failure, encephalopathy, you have to remember. Okay, so here we have completed neonatal hepatobiliary GI and nutrition part, which is actually very much important. I have just discussed the very ultra high yield point from this topic. So go through this video again, and this is this I hope it will be beneficial for you. If you like this video, do share, like, and subscribe. I will be we'll meet in another video of this series. Okay, we'll discuss another topic of this neonatal high yield series. Till then, we'll meet in